Hello, everyone. Welcome. And we should start now. It's 4:03, so welcome and thank you for joining tonight. For those who don't know me, my name is Ana Araujo. I'm a nutritionist. I've been a nutritionist for 25 years now, and I'm also a menopause specialist by the IMS, the International Menopause Society. And I'm super happy to have Dr. Carla DiGirolamo today. She will be talking about hormones in the menopause transition. And it's a super important topic because there's a lot of misinformation out there and some confusion. So nothing better than an expert in the female physiology to talk about that. So let's jump right to it. Oh, before I forget, we will have a little bit of a Q&A at the end, so stick around for that if you want. And some people send me questions as well, so we'll get to those at the end. Okay, so let's introduce this amazing woman, Carla DiGirolamo. She is a double board certified reproductive endocrinologist and OBGYN. She works for the Boston IVF. She's among the top doctors in the Boston area. She's also featured in Boston magazines in the 2019, 2020, and 2021 edition. She is also in the provider list for the NAMS, the North American Menopause Society, as a certified menopause practitioner. And Carla is not your typical doctor. She's also a CrossFit trainer, a certified nutrition coach, and body combat and body pump instructor. She recently launched an online personal and nutrition coaching business, Fit for Life MD. That's also her Instagram account, specializing in the care of women of all ages, but she has a special care for women in the menopause stage. Carla has been featured in many podcasts and media sources discussing the benefits of CrossFit for midlife women and various topics related to perimenopause and menopause, hormone physiology, and hormone therapy. She was also invited to be a speaker at the Feisty Performance Summit this year. That's where I saw her for the first time. And she's actually talking about giving the same presentation called Hormones and You, Knowledge is Power. Carla completed her residency at Women and Infants Hospital of Rhode Island at Brown University Medical School and her reproductive endocrinology training at the Massachusetts General Hospital at Harvard Medical School. Carla is married to her husband, David, of 19 years, and they have a 15-year-old son Nick, and a 4-year-old beagle named Sasha. Fitness is her passion that fills every waking moment that is not spent practicing medicine. The beach and her home/gym in Narragansett, Rhode Island is her place of serenity. So welcome, Carla. Thank you for being here and sharing your knowledge with us.
Well, thank you for having me, Anna. What a great introduction. I really appreciate it. And I'm thrilled to be here to be able to talk to your members. So with that, I will jump in. Title of my talk is Hormones and You, Knowledge is Power. And first off, I don't have any financial conflicts of interest with anything that I'm going to be presenting today. And the objectives of our talk, I'm going to minimize this, are to understand the basic hormonal function in the pre and perimenopausal menstrual cycles. We're going to review how hormones interact with other bodily systems in perimenopause and in menopause. We'll explore how hormone therapy fits into these physiological processes and changes, and we'll discuss the future of hormone therapy and how we navigate the current landscape. So the other objective is to, of course, keep everyone awake because we know that hormones can be a very dry topic. But hopefully we will manage to do that. So first thing, we'll talk about the menstrual cycle. So this looks a little complicated, but to just boil it down, the menstrual cycle begins with the first day of your period. That's considered day 1 of your cycle. And in the first 14 days is what we call the follicular phase. And that is the phase where the pituitary gland is producing the hormone follicle stimulating hormone, or FSH. And what it's doing, it's stimulating the ovaries to generate an egg that will ultimately be ovulated. So around the 2-week mark, the egg is usually ready, ovulation happens. And then what the ovary does, in the place where the egg used to be, it forms this organ called the corpus luteum, which produces progesterone. And what the progesterone does is it gets the uterine lining ready for implantation. And then if no pregnancy happens, then the lining regresses, the progesterone levels go down, and your period starts all over again. So that's just an overview of what the menstrual cycle is. Now, one way to think about all of these hormones and all of these things that happen in the menstrual cycle is to think about it. It is a rhythmic and predictable conversation among the hypothalamus, which is an area of the brain, the pituitary gland, the ovaries, and the uterus, where the hormones are the language that they all use to communicate with one another. So it's one big conversation, and the hormones are the language that they are speaking to get the messages to one another in that very rhythmic, synchronous way. So just to give an illustration here, so on the left hand of your screen, that's the pituitary gland. So the first thing that happens is the pituitary gland wants to tell the ovary to make an egg. So the language is FSH, like I mentioned. So pituitary gland is saying, hey, it's time to make an egg. So the ovary hears this message and says, oh, I'm being asked to make an egg. So the ovary makes the egg. And so then the ovary, once the egg is made, has to tell the pituitary gland that we have an egg. And the way the ovary does this is through the hormone estrogen. So the pituitary gland sees the estrogen, and that's the message that the egg is ready. So the pituitary gland says, okay, we have an egg. We're going to ovulate that egg. And so ovulation, so we have to tell the ovary to ovulate the egg, and the hormone LH, luteinizing hormone, is the message to the ovary to say, all right, ovulate that egg. We're ready to go. So then the egg ovulates. And like I mentioned before, the next hormone that comes into the conversation is progesterone. Now the uterus comes into the conversation, and the ovary is basically telling the uterus, hey, an egg's coming down the pike. We could be encountering a pregnancy. So then the sperm comes along, and then the sperm fertilizes the egg, and then an implantation happens. So now the baby gets involved in the conversation. The baby's got to let everybody know that they've landed. So the way they do that is through HCG. That's the pregnancy hormone that turns your pregnancy test positive. And so that HCG is the message to the ovary to say, keep that progesterone moving, I'm here. And then the uterus is like, okay, we got a pregnancy. The progesterone is telling me to keep that lining nice and thick and fluffy so that we can continue on as a pregnancy. Now, if a baby does not arrive and there's no pregnancy, eventually we have our period. And what happens is the progesterone levels go down. The ovary is looking for the signal that there's a pregnancy there. The ovary is not seeing HCG. So the ovary gives up and says, all right, maybe next month, stops making progesterone, and then menstruation happens. So that's an example of what I mean by the conversation that happens among all of these things to have a menstrual cycle every month. Now, I mentioned before that in premenopause, this is when we're in our 20s and our 30s and we're having periods and we're having children, our periods are very rhythmic and predictable. And so in the panel on the left, you can see a very regular pattern that emerges there. In perimenopause, when ovarian function is beginning to decline, that pattern becomes more erratic and the signals become more erratic. So what happens is the conversation is not quite as clean and crisp as it was before. So when we think about the perimenopausal conversation, instead of being a nice, rhythmic, easy conversation, it is instead a lot of chaos. So the way I referred to it at the summit was it's a shit show. And it basically is a shit show. You've got hormones firing on all cylinders with no synchrony, with no rhyme or reason. And that's why we feel the way we do in perimenopause, is just because there's a lot of hormonal chaos going on and it's very unpredictable. So what are these hormones? What are hormones and receptors? We hear a lot about these things, but what are they? So hormones are signaling molecules that are produced by endocrine glands. Examples are the pituitary gland, the thyroid gland, the adrenal gland. And these signaling molecules are secreted into the bloodstream so that they can travel to various tissues and communicate a message so that the tissue can function in a certain way in response to the hormone. Receptors are like antennae to pick up those signals. They're actually proteins that live on the surface of cells in various tissues and organs. And their job is to accept that signal, to pick up that signal, and to translate the message to the cell so that the cell knows what to do in response to the hormone. Specific receptors identify and receive signaling from specific hormones. There are some overlap, but there is some specificity there. For example, the ovary may not so effectively respond to thyroid hormone, but it does recognize follicle stimulating hormone when it's ready to make an egg. So there's FSH receptors, but there may not be thyroid receptors in the ovaries. So that's an example of the specificity of receptors. Now, these receptors, these signaling, these proteins that pick up the signals are everywhere in the body. Now, what is the relevance of this? So we see estrogen receptors in the brain, the cardiovascular system, the breast, the liver, the reproductive tract. And what that means is when you find a receptor on a tissue, it usually means it's responsive to that hormone. So if there's an estrogen receptor in the brain, you know it's doing something. If there's an estrogen receptor in the liver, you know it's doing something. So what that tells us is that estrogen has an impact on almost every tissue in the body. So when we have erratic signaling in this dysynchronous pattern in perimenopause, and we've got almost every tissue in the body getting these dysregulated signals, it kind of feels like that. You kind of just want to scream because the body just doesn't necessarily know what to do with all of these chaotic hormones. And that's why moods are the way they are. That's why maybe our digestive system doesn't work so well. And that's why cardiovascular risk goes up and various other things that we know happen in perimenopause. All has to do with the various tissues involved in estrogen signaling. So what we know is that there are many organs and tissue systems that are responsive to reproductive hormone cycles, like I just mentioned. But what we don't know is how these tissues interact with one another in response to reproductive hormones. So what we know, meaning like what we've researched through the years and what we can measure in the bloodstream, is really only the tip of the iceberg. What the reality is the rest of the iceberg underneath. And what this whole thing represents is the menopausal experience. So there's a little bit that we do know, but there's a whole heck of a lot of physiology that we don't know and that we can't measure. And so therefore, my focus is to treat the menopausal experience. We use lab testing, we use the knowledge that we do have to guide us, but we have to, at the end of the day, consider what the menopausal experience is. That's the total iceberg. And that's what we're trying to treat and what we're trying to solve when women come to see us for those types of problems. So we've been talking a lot about perimenopause. I want to talk a little bit now about menopause. So what is menopause? Menopause, the diagnosis is made at the point in time 1 year after the last menstrual period, okay? FSH, LH does not diagnose menopause. You can be in perimenopause and have an FSH of 100, which is a quote unquote menopausal level, but that's not how the diagnosis is made. It's when you are 1 year beyond that last menstrual cycle. So once you're in that position, things settle out a bit. So if you look at the right-hand panel, this looks a lot more serene. Not as much chaos. Things have kind of settled out into a new normal. It's like a forest fire. Perimenopause is kind of like the blazing forest fire. And once the fire goes out, that's kind of like menopause. That's what you're left with. So it's a new normal. The fire is no longer burning, so there's a little bit more stability now, but it's at a new level. Estrogen levels are at a new level, testosterone levels are at a new level, progesterone, et cetera. So some things get better that are no longer changing all the time, and other things will continue to either stay the same or maybe not get better. And we can talk a little bit more about that. But in large part, menopause is defined by a settling out of that hormone chaos that we experienced in perimenopause. So far, the key points I want you to take away from this is that the premenopausal menstrual cycle is synchronized and predictable. Perimenopause is more erratic and unpredictable. Estrogen receptors are widespread throughout the body and exert widespread effects in response to estrogen and changing estrogen levels. And changing hormone signals, therefore, impact many organ systems, exerting a range of physical effects. And again, how they interact with one another in the body is still the subject of great research and is very unknown. But the field is advancing and we're learning more and more every day. But there is still a lot we don't know. So now let's talk about managing the menopausal experience. So when a woman comes to me with a problem, my first step is to assess the severity of what she's experiencing, the duration, how long has she been experiencing it, and exactly what is she experiencing. Once I know this, the next step is to exclude other medical problems that could be causing those signs and symptoms, like hot flashes may be perimenopausal, or they could be due to a thyroid issue. We have to exclude thyroid function issues to make that determination so that we can best design the therapy that's going to work for her. We need to figure out what are the goals of her symptom management. So I might have someone that says, look, I'm having hot flashes at night. I can't sleep. I just need to sleep. I can't function. I don't care if I have them during the day. I just need to sleep at night. So then you know, okay, our goal is to help her to sleep better. We may not need to get rid of hot flashes completely for her, but if we can get her to sleep at night, we're going to be doing a great service for her. We want to discuss the foundational elements of health maintenance. Now, I can't overstate this enough. So if someone's nutrition isn't sound, if nutritional habits are not optimal, that could also be an explanation as to why they're having their experience. So my woman who's having hot flashes at night, if she's drinking a 24-ounce Starbucks coffee at 9 p.m., well, we may want to change that because that in and of itself may improve her situation dramatically. So we want to explore fitness and nutrition and what the lifestyle is like in response to, trying to solve her problem and how it relates to her problem. And then once we have sorted all that out, we talk about management options, risks, and benefits of various treatments and interventions. So the risk-benefit analysis, this is very, very, very important. It's unique to every individual woman who comes in because it is a very big picture analysis. So we're assessing the balance between the severity of symptoms and the likelihood that a given therapy is going to resolve those symptoms and the risks associated with the therapy. So for example, I'll go back to my hot flash patient. We know that estrogen or combined estrogen progesterone therapy is very, very effective for treating hot flashes. So that is something we would consider once we've ruled everything else out. The risks, there are some risks to hormone therapy for certain individuals. So if you are somebody that has a blood clot history, if someone who makes blood clots in their veins, that can be a very dangerous situation, or potentially some other risks. So you want to go, into her history and say, okay, here are the risks and here are the benefits. And if the benefits outweigh the risks, that says, okay, then let's try this. So as I mentioned, every individual's risk-benefit analysis is unique to them. There is no one size fits all for everybody. This is a very individual decision that we make with each individual patient. So let's dive in a little bit to hormone therapy. This is going to be a really cursory overview of just some very basic general things to consider. I could do a 3-day retreat on hormone therapy. It's a very complicated field, or it's a very complicated subject. So we'll just kind of go over the basic essentials here tonight. So there are 4 very basic types. There's estrogens, 17-beta estradiol and its derivatives. There's progestins, which is like micronized progesterone and its derivatives. There are therapies that combine estrogen and progesterone. And then there's testosterone and androgenic derivatives, such as DHEA. Hormones can be taken many different ways. They can be taken orally as a pill. They can be taken as a skin patch, a gel on your skin, a spray, and they can also be taken vaginally. So many routes of administration to various hormone therapies. Bioidentical and compounded HT. Well, what is bioidentical? What does that mean? We hear it all the time. It's a big buzzword. A bioidentical hormone is a hormone that is identical in structure to the native hormone, meaning that's the one that the ovary produces. So the estrogen that the ovary produces is 17-beta estradiol. Now, there's other estrogen derivatives that are naturally produced. There's estrone and many other things, but just for the sake of simplicity, 17-beta estradiol is the big one that we all know about. And micronized progesterone is also bioidentical, produced by the ovary after ovulation. Now, when we think of bioidentical hormones, we think about the compounding pharmacy that, okay, my naturopath gave me a prescription and it's bioidentical. Well, there are FDA-approved bioidentical products out there too. It doesn't have to be given to you by a naturopath. Estrace is an example of FDA-approved 17-beta estradiol, and Prometrium is an example of bioidentical progesterone. It's micronized progesterone. So there are bioidentical FDA-approved therapies out there, okay? And so, well, what is compounded HT then? Well, what compounded HT is, it's a customized prescription that's written by a provider with a certain combination of hormones that may be prescribed. We often use compounding pharmacies if there's no FDA-approved comparable preparation with the desired route or dose. It's just not available, so you can actually design it yourself for your purposes. The advantages of compounding pharmacies and compounded HT is the ability to tailor a preparation, vehicle, and route of administration to a woman's needs. But the cons are that these customized preparations have not been subjected to rigorous study for safety and efficacy, and there is also limited oversight of compounding pharmacies for safety, purity, and consistency practices. Now, one point I want to drive home here is that not all bioidentical HT is compounded. Like I said, there are some FDA-approved preparations out there. And not all compounded HT is bioidentical. So just because a provider writes a prescription for a combination of hormones, it doesn't necessarily mean they're the same hormones that are produced by the body. They could be synthetic hormones that are incorporated into this prescription. So just know what the definition of bioidentical is, because it is also out there as a marketing term, and sometimes it can be deceiving. So know that bioidentical simply means it's identical to the body's natural hormones. So how do I know which hormone therapy is right for me? The things that you want to be considering when you are discussing this with your provider is, first, the route of administration. The oral route or pills are the most common way to take hormone therapy. But the thing you need to know about oral preparations is this phenomenon called the first pass liver effect, okay? The first pass liver effect occurs when you swallow the pill. It goes into the stomach, and then it goes into the intestines, and then it gets absorbed by the intestines. And as soon as it's absorbed into the circulation of the intestines, it goes straight to the liver, okay? Goes to the liver for detoxification. Now, the liver does a gazillion things in the body. And when it sees hormones, other things happen. So clotting factors, blood clotting factors are produced by the liver. We know that hormones can upregulate the production of clotting factors, and that can put people at risk potentially, given their risk profile. There is an increase in response to estrogen to a protein made by the liver called sex hormone binding globulin. It's a protein that tends to mop up testosterone and other androgens in circulation. So it can have that effect on reducing acne when you're a teenager. That's why we give you birth control pills when you have acne, is because of the sex hormone binding globulin. It mops up all those extra male hormones. It can also impact liver enzymes. So estrogen can impact enzymes in the liver that may metabolize other things. So that might have implications for other medications that you're taking and the potency of those medications. So that's with the oral route. The transdermal route, which is like a patch or a spray or a cream, avoids the first pass liver effect because it goes on your skin, it goes into the blood vessels in your skin, it goes straight into circulation, it doesn't go to the liver first. So it avoids the upregulation of all that other stuff in the liver, and that can be a very favorable thing. So it's important for blood clot risk. If you have somebody who's at risk for blood clots, you may not want to give them oral estrogen. You may want to give them transdermal estrogen instead because of that first pass liver effect. Because of the sex hormone binding globulin upregulation and the testosterone, mopping up the testosterone, like I mentioned, that can also impact libido. So it might make your face much clearer, but it can also impact your sex drive negatively. And transdermal may have less of an effect in that way. Other medications like antibiotics that you might be taking, the potency may be impacted from liver enzyme regulation. And on the flip side of that, if we're doing transdermal patches, allergy to adhesive tape might be a consideration. If you are a swimmer or if you sweat a lot, patches sometimes will fall off, so that might not be the best route. There are fewer available preparations by the transdermal route as compared to the oral route. And also, what's the therapeutic target? If you have vaginal atrophy, you don't want to necessarily be taking systemic or oral estrogen for that. You want to take vaginal estrogen for that. So that's another consideration of where are the symptoms as to what the route of administration of your hormone therapy is. So other considerations is, well, all right, we're going to start this. This is a good idea. How long do I stay on it? Well, we don't have to figure that out immediately, but the things that we keep in mind when we're trying to determine the duration of treatment is how old is the woman when she starts treatment? We know that the older a woman is and the further out beyond menopause that she is, the more risks that come along with hormone therapy, such as blood clots and cardiac events and vascular events. What symptoms are being treated? Are we treating hot flashes? Are we treating vaginal atrophy? And what are the natural courses of those symptoms? Like hot flashes will eventually go away, so you may not need hormone therapy forever, whereas vaginal atrophy continues to get worse with time. So you may be on vaginal estrogen for the long term. What are the balance of the risks and benefits? We've talked about that. And what other medical conditions may or may not benefit from prolonged treatment? So say I have a woman who is a type 1 diabetic and she is lean and she is fit and mom had a hip fracture. Well, she's at very high risk for osteoporosis. So maybe her hot flashes have gone away, but I may keep her on hormone therapy because she's at such high risk for osteoporosis, and the estrogen is going to help her prevent that. So lots of things go into that equation. And duration, like I said, doesn't need to be, determined at the outset of treatment. It's an ongoing assessment. So you might have someone on hormone therapy for 5 years. You revisit the situation in 5 years, see where we're at, and then you might decide to stay on for another 2 or 3 years, or you might decide to stop. Depends on what's happening at the time. So it's an ongoing assessment, and it doesn't need to be worked out at the time of starting the treatment. I want to talk a little bit about testosterone because this is such a hot topic. It is not FDA approved for any indication in women, sadly enough. There is a substantial body of literature showing the safety and the efficacy in postmenopausal women with hypoactive sexual desire disorder. Now, hypoactive sexual desire disorder is just loss of libido, interest in sex, that is bothersome to a woman. That is the diagnosis. It's not through testosterone levels. The diagnosis is made is if she's having bothersome libido issues that are interfering with her life. Other potential indications may be to prevent muscle wasting, to improve athletic performance, and some of the genitourinary syndrome of menopause, like the urinary symptoms, the vaginal atrophy, painful sex, etc. The dosing for a woman is 1/8 to 1/10 that of that used in males. This is an example of when you might use a compounding pharmacy because there are no female FDA-approved testosterone products. You're stuck with the male dose in trying to sliver off 1/10 of that. That isn't always the most accurate, safest thing to do. So you may want a compounding pharmacy to compound a cream or whatever that is the right dose for a woman. So that's an example of when it would be reasonable to use a compounding pharmacy. Again, you always want to balance the risk and benefits, and you always want to monitor testosterone therapy. The therapeutic goal is the premenopausal range of testosterone. So total testosterone is one way to measure it, and also the free androgen index is another way that your doctor could follow your testosterone treatment. But the goal is to stay within what the normal range is for a premenopausal woman. If you start going beyond that, there can be side effects like temporal balding, deepening voice, which is irreversible, hair growth, things like that. Ineffectiveness. You want to make sure that if you are going to give someone testosterone therapy, that it has a good chance of working and solving their problem. Now, for those of you in the audience, and many of you are competitive elite level athletes who do events that have restrictions on substances and testing and so on, testosterone is a banned substance in the sports industry, as is human growth hormone. So if you are on testosterone therapy for menopausal symptoms, you're definitely going to want to go off of it before your event or disclose it. Disclose any of your medications or supplements to the event managers, and get a note from your doctor about the reason for why you're taking these treatments that might be banned for the event. I do this a lot for my fertility patients because a lot of the medications we use for IVF will trip a positive test. And so I have to go into these very big, long forms describing the types of medications we use and why we use them. So just be transparent and upfront before your events and disclose anything that you're taking for your menopausal experience. So what does HD do? What does it do? It can result in dramatic improvement of quality of life. It can effectively treat vasomotor symptoms or hot flashes. It can also effectively treat vaginal atrophy and some of the genitourinary symptoms of menopause. With appropriate timing and duration and risk-benefit analysis, it can reduce cardiovascular risk, reduce the risk of some cancers, maintain cognitive function, improve sexual function, and prevent osteoporosis. Hormone therapy really does a lot of good things. But what does it not do? What it does not do is recreate the same hormone environment from before menopause. There is no way to reproduce that identical environment because regulation of hormones and all of those signals goes way beyond the level of the hormone. It's the pattern that the hormone is secreted in pulses that also is a critical component of messaging to tissues. So if that's not confusing enough, check out this slide. This is even more confusing, but I'm gonna boil it down for you. If you look up in the upper left-hand corner, if you look under panel A, you see spikes, right? And they're happening at a certain pattern. Then if you look at the one right next to it to the right, you see the spike pattern start to change. This is what happens with LH secretion at the time of ovulation. So ovulation isn't just induced by the presence of LH or the level of LH, it's the pattern of LH secretion by the pituitary gland that tells the ovary exactly what it needs to do. So the analogy is like the difference between communicating by email versus an in-person conversation. An email misses human nuance, body language, that can be very important for conveying the right message, because we all know we use email. Sometimes that email message can go wrong and the messages can go wrong. And that's why sometimes things go wrong with hormone therapy, is because we can't recreate that native environment that we once had. We still can do a lot of good and treat a lot of symptoms and feel a lot better, but we can't recreate that same hormonal environment. Now, some other examples of processes that happen that are dependent on pulsatile frequency is the onset of puberty, the initiation of labor for childbirth, ovulation, as I mentioned, and there are likely many others that we probably don't even know of yet. So this is an important point, that we can help things, but we can't recreate the environment that once existed. So again, key points. The human endocrine system is an extraordinarily complex system where much is still unknown. The decisions surrounding any therapy are driven by a carefully constructed risk-benefit analysis. Route of administration, duration of treatment are among the important considerations to discuss with your provider if you're initiating hormone therapy. And HT has many potential benefits. However, it does not restore the native premenopausal hormonal environment. So where do we go from here? There are lots of barriers to women getting hormone therapy. There's lack of specialized providers. A lot of providers don't feel comfortable prescribing hormone therapy because of, many studies of the past that may have scared the bejesus out of people unnecessarily, has left a lot of providers very skittish about hormone therapy, unfortunately. Societal impressions of perimenopausal and menopausal women. They think that we should just die on the vine, and that's really sad, but it's the truth. And so there is just that tendency. It's like, well, you're getting older, just accept it. It's just the way it is. Well, damn it, we don't need to accept it. So when there's treatments out there and we want to be the best that we can be, why not pursue that? Because we're not dying on the vine, not this group. And then there's the medical status quo. If we have no data, we shouldn't do it. Well, you know what? I have to get some sleep tonight. I have to be at a meeting tomorrow. I got to raise some training for, so I don't have time for the double-blind, placebo-controlled, randomized controlled trial to come out 10 years from now. I need a solution now. And that, in my opinion, spending as much time in the medical community as I have in academics, is where medicine really falls short. There's this analysis paralysis where if they don't have data, then they don't quite know what to do without it. So those are just some of the barriers. So what we need to do to overcome these barriers, we need to reinvent the way we approach managing this phase of a woman's life. We need to provide women with the knowledge they need to make their own decisions. We can't rely on the medical community to spoon feed this to us. It's just not going, that just doesn't work for us. So we need to empower ourselves with great support around us and with reputable, reliable information. We need to educate providers. That's my job. As a menopause specialist, I like to work with generalist OBGYNs and primary care doctors to help them understand better the menopausal experience so that they can treat their patients better. We need a fresh approach to who should and who should not use HT. Again, if we have no data, we shouldn't use it is obsolete. We need to do better than that. More research specifically on peri and menopausal women is much, much, much needed. And we all need to come together and support each other. So with that, I thank you for your attention and for listening to me for the last half hour. I am happy to take any questions you all may have.
Thank you, Carla. That was great. Just as good as the summit.
Oh, good. I'm glad.
So good, so good. And I'm so glad that you have this vision of supporting women and, just educating us, right? Because we do have kind of to support each other, right? Learn, and there's so much confusion out there and misinformation, people trying to take advantage, sell products and tests and things like that, right? So exactly. Yeah, it's great to have just providers like you helping us. So I do have some, I think there's someone that wants, if you want to put on the chat or if you want to just talk, you can do that, but I will go ahead. I have some questions here that some people sent. Someone asked, how do I cope with menopause symptoms if I can't have HRT due to breast cancer?
Yes, it depends on what those symptoms are. I look honestly to fitness and nutrition as the first go-to try to manage the menopausal experience. Like I said, there's a lot of There's a lot of things that may not be optimal about our diet that could be impacting how we experience menopause. You know, there was a post that I put out on my Instagram and on my Facebook a couple of weeks ago. It was something I saw in the journal Morning CrossFit in the newsletter. And it's basically the symptoms of not eating enough are just like perimenopausal symptoms. And so, especially with elite level athletes or avid recreational athletes, you may be working out and training 10, 12 hours a week. And if you're not eating enough, you're going to get the brain fog. You're going to get the fatigue. It's going to be hard to sleep at night. You're going to get the
availability.
Yeah, because you're in an energy deficit.
Yeah.
So the first place I would look, especially if hormone therapy is not an option for you, is to get a really good nutritionist who can, you know, dissect what can be improved, what kind of dietary supplements are out there. You know, some of the adaptogens can be very effective for managing menopausal symptoms, ashwagandha, shisandra, some of the various ones that are out there. Black cohosh has some data behind it, soy. There's certainly non-hormonal remedies out there for people. And also there are a lot more medications, like FDA approved medications that are non-hormonal that are making their way into circulation. So a menopause specialist and a nutritionist are probably the two places to go to look at dietary management and alternative therapies to hormone treatment.
Okay, great. The second question, if I don't have anyone here asking, is how do you know when to start? Is in full menopause or before?
It depends. And if you're having a problem, not everybody needs hormone therapy. You know, there are plenty of people who, you know, experience changes, but they're not disruptive to their lives. So, you know, if you don't need a medication, then why take it? Since all medications have their associated risks with them. So if you're not having a problem, you may never need to go on them. There's no right answer that's right for everybody. But if you're having symptoms as a perimenopausal woman, there, you know, you may want to be on some hormone management in perimenopause. But if you're not having symptoms, then you may not need it.
Okay. And then the other question is, how does HRT, you use more hormone therapy, HT, right? Instead of the replacement.
Well, because I'll tell you why, because again, this goes back to you cannot recreate the hormone environment of the past. So you're not replacing anything. Because in menopause, it's normal for estradiol levels to be low. It's normal for testosterone levels to be low. Now, that doesn't mean we have to live with the effects of that.
Right.
It's just physiologically, that's normal. So you're really not replacing anything because you can't recreate that premenopausal hormone environment. So the menopause community has stopped using the term hormone replacement therapy, and it's replaced it with hormone therapy.
Yes.
That's the nuance there.
Yeah, we should use HT instead of HRT. So the question is, how does HT affect other medications? And you talked about this a little bit, right? There's sometimes there's interaction.
Yes, it depends on the medication. It depends on how that medication is metabolized. Most medications are metabolized in the liver. And so usually what you'd want to do is talk to your pharmacist, because the pharmacists have these really cool databases that you put in the medications and interactions come up. So if there is an interaction and you have like a long list of medications, then your pharmacist will find it for you. But it's definitely a question you should ask if you are taking multiple medications. Now, the other thing too is medications aren't the only thing that can affect liver metabolism. A lot of supplements can too, like vitamin E, garlic are all blood thinners. So if you are taking those as supplements and, you know, you're taking ibuprofen for something, which is also has blood thinner effects, you might be at risk of some bleeding. You know, bleeding a little bit more so than if you weren't taking them. So supplements also are in that category too. And so when you're on many medications, you always want to check with the pharmacist. They can put it in a database and help figure that out.
Great. And then the last one, someone asked, what's the best way to balance hormones and facial hair?
Well, we first have to figure out why the facial hair is there. You know, what's the surrounding physiology behind why there is facial hair? Is there insulin resistance going on? Is there androgenic overload? God forbid, is there a tumor somewhere that we need to rule out? But in general, like polycystic ovarian syndrome, or PCOS, is a very, very common disorder that I see a lot of as a fertility specialist. There's a lot of hair growth there. And what a lot of people do to manage hair growth is they go on birth control pills. And what the birth control pills do is it upregulates that sex hormone binding globulin, and that sucks up all of the excess androgen or testosterone, and that helps to reduce hair growth. So that's one of the more common things we use to manage hair growth. If you're postmenopausal and having hair growth, that's definitely something that should be evaluated. Because like polycystic ovarian syndrome is just a whole bunch of reproductive hormones being produced all asynchronously. But in menopause, you shouldn't have that. So if you have hair growth and you're postmenopausal, definitely check that out with your provider.
Yes. Okay. And I think that's it. Oh, wait, there's one more, sorry.
Okay.
So my doctor prescribed birth control pills, but I haven't been officially in menopause yet. Is this equivalent to HT? And if so, is it better or worse in terms of possible side effects?
This is a really great question. I get this one a lot. So the reason we use birth control pills in perimenopause is the purpose of the birth control pill is to try to even out some of that chaos, right? It's to try to add some order to the shit show we know of as perimenopause. And to do that, that requires a higher dose of estrogen and progesterone. And so you find those higher doses of estrogen and progesterone in birth control pills. In menopause, once the forest fire's gone out and you're not worried about, stemming the flames, you can use lower doses because you're not trying to even out any hormonal chaos. Everything has all settled out. So the doses we use postmenopausally are much, much, much lower. Because they don't have to be higher. So that's the difference between perimenopausal hormone therapy, like birth control pills, and menopausal hormone therapy. It's all a matter of dose.
Yeah, makes sense. So I'm gonna let you go. I'm so thankful for your knowledge and even your personality is great, Carla. Thank you so much. And I'll make this available, and I'll also put your information to anyone that later sees this recording and want to contact you in any way. And I'll put your Instagram account and all that stuff too.
Yeah,
thank you so much for your time. I really appreciate it. That was great.
Thank you,
for
Anna.
all
Thank
you
for
do.
having me.
Thank you. Have a great night.
You too. Bye-bye, everybody.
Bye.